In any NTOPD, a major portion of patients will be having complaints of change in voice or difficulty in breathing. So for this we need knowledge of anatomy of larynx and also innervation of larynx. Regarding anatomy of larynx, it was described in an earlier video. So please go through that and study. And today's class is on innervation of larynx. Okay, innervation of larynx. Which nerve supplies larynx? That is hidden inside the name larynx itself. And this larynx is supplied by which nerve? 10th nerve. So the larynx, both muscular and sensory supply is from 10th nerve or the vagus nerve. And this vagus nerve supplies both motor and sensory innervation of larynx, and it also supplies, along with larynx, it supplies palate, pharynx, then after larynx, the trachea, bronchus, lungs, heart, external ear, and also some parts of gastrointestinal tract. Okay, so the larynx is supplied by vagus nerve. Okay. Now, how this vagus nerve supplies larynx? So the fiber supplying this area is constituted in nucleus ambiguous. Okay, nucleus ambiguous, and this is in midbrain. So the nucleus ambiguous is situated in midbrain, and the fiber supplying the area of larynx is coming from nucleus ambiguous, and the fibers supplying higher areas are situated higher up in the brain. Okay, so nucleus ambiguous is in midbrain, and actually it has got an upper portion and a lower portion, and fibers from upper portion of the vagus nerve has got, actually the vagus has got two friends there. They are the 9th nerve. We always write cranial nerves in Roman numbers. Okay, and also they have a 11th nerve and 10th. So this 10th nerve has got two friends, 9 and 11. So the fibers from upper portion of this nucleus ambiguous join with that of ninth nerve, that is the glossopharyngeal nerve, and fibers from those of lower portion, they go along with the 11th nerve, that is the accessory nerve. Okay, so in lesions of midbrain, especially those affecting the nucleus ambiguous, you can get a combined paralysis of 9, 10 and 11, and that is why they call it as a glossopharyngeal accessorious complex. Okay, glossopharyngeal accessorious complex. So now you know what happens at the level of midbrain, and after that all the fibers of the vagus, they combine together, join together and come as a flat curve and come out of the skull through jugular foramen, and after jugular foramen they go vertically downwards from the base of skull, it go downwards. Okay, a vagus nerve in the neck gives three branches. They are the superior laryngeal nerve, the recurrent laryngeal nerve and the pharyngeal nerve. So we will see what are the supply or the course of each of this. This vagus nerve, it exits the skull through jugular foramen. Okay, jugular foramen. Vagus nerve exits the skull through jugular foramen, and at the exit of the jugular foramen there are two ganglia. One is superior ganglion and another one is an inferior ganglion. but the superior ganglion is smaller. S and S. Okay, they go hand in hand. Superior ganglion, otherwise called the jugular ganglion, which is smaller one, and the inferior ganglion is larger one, and it is called the nodose ganglion, ganglion nodosa. Okay, and this one is jugular ganglion. Superior one is smaller and it is called the jugular ganglion. Inferior one is larger and it is called the nodose ganglion. Okay, and after that it descends in the neck between in the carotid sheath between the common carotid artery and internal jugular vein and up to the root of neck. And in the neck, the vagus nerve, we are concerned about only in the area of neck. So in the neck, this vagus nerve has got 3 branches. One is next is recurrent laryngeal nerve. Recurrent laryngeal. And the third is pharyngeal nerve. Okay, pharyngeal. Right? So in the neck, vagus nerve gives off 3 branches: recurrent laryngeal, external laryngeal, recurrent laryngeal, and pharyngeal branches. I hope these diagrams are familiar to you. If not, just see my video on anatomy of larynx, because without knowing the anatomy, it will be difficult for you to understand this innervation, right? So be thorough with the anatomy of larynx. Then after that, come and see this, right? So this external laryngeal nerve arises from the inferior ganglion, or the nodose ganglion. I already told you there are 2 ganglion outside the jugular foramen, a smaller superior one and a larger inferior one, which is called the nodose ganglion, and this external laryngeal nerve arises from the nodose ganglion or the inferior ganglion, and it goes lateral to the pharynx and hyoid bone. At the level of greater horn of hyoid bone, it divides into a smaller external branch, and a larger internal branch. Okay. Internal branch. So this external laryngeal nerve at the level of greater horn of hyoid bone divides into a smaller external branch and a larger internal branch. This external branch is mainly motor to cricothyroid muscle. This is cricoid cartilage, thyroid cartilage and cricoid cartilage, trachea, tracheal rings, hyoid bone. So this muscle cricothyroid. So this external branch supplies cricothyroid muscle, and also it gives fibers to, along with pharyngeal nerve, it gives fibers to pharyngeal plexus. Okay. So external branch to cricothyroid muscle and also supplies to pharyngeal plexus. And this larger internal laryngeal nerve, what happens to that? It go, and what is this membrane? Thyrohyoid membrane. Okay, thyrohyoid membrane. So this larger internal branch pierces this thyroid membrane above the level of superior laryngeal artery. So superior laryngeal artery actually comes this way. Okay. So actually this internal branch of external laryngeal nerve pierces the thyrohyoid membrane above the level of superior laryngeal artery. There are variations, but commonly it pierces the thyroid membrane above the level of superior laryngeal artery, and it is basically sensory as well as secretomotor. It carries sensory fibers and also parasympathetic secretomotor fibers to supraepiglottic or mucous glands above the level of vocal folds. Clear? So, internal branch of external laryngeal nerve is basically internal branch contains sensory fibers also parasympathetic secretomotor fibers. Sensory to where? Sensory fibers basically to pharynx, then vallecula, then to epiglottis and the laryngeal inlet above the level of vocal folds. Okay. And the secretomotor to supraglottic nodes, supraglottic glands. Okay. At the submucosal level, there are so many mucous glands, so it supplies that supraglottic glands. So basically, sensation above the level of vocal folds are supplied by the internal branch of external laryngeal nerve. And actually, it has got three branches, and first two branches supply the pharynx, vallecula, epiglottis, and also the laryngeal inlet. And this third branch, it goes downwards along the medial wall of pyriform sinus and supplies there. Along the medial wall of pyriform sinus and supplies a mucosa there. And that forms an anastomosis with the recurrent laryngeal nerve, that I will tell you. So I hope it is clear to you. And this external branch of external laryngeal nerve, it descends towards the superior pole of thyroid cartilage and on the surface of inferior constrictor muscle, and it supplies this cricothyroid muscle, which is the only tensor of the vocal cords. Okay, so cricothyroid muscle, that is important. You have to remember that it is the only muscle supplied by this external laryngeal nerve. Okay, that is cricothyroid muscle, and it also supplies branches to pharyngeal plexus, which is from pharyngeal nerve, that I will tell along with the description of pharyngeal nerve. And here you can see that this internal branch supplies sensory innervation of this larynx above the level of vocal folds, and the longer third branch of the internal branch, it goes through the medial wall of pyriform sinus. So at the medial wall of pyriform sinus, if you anesthetize this now, the excellent anesthesia of the pyriform sinus can be obtained. That is one thing. And also this internal branch is liable for injury during surgeries done on these areas. Okay, so that is the clinical importance of that. And regarding recurrent laryngeal nerve, the course is different on both right side and left side. Here this is a posterior view. Don't confuse with this picture. This is left side and right side, as you are seeing from behind. So I am standing like this, my right, and this is my left side. Okay, posterior view. This is an open view from behind. Right? So this recurrent laryngeal nerve is branching from the vagus nerve, and on the right side it is given off at the level of right subclavian artery, and the subclavian artery, okay, right side. So it where this vagus nerve crosses a subclavian artery, this right recurrent laryngeal nerve is given off, this one, recurrent laryngeal nerve, and it crosses the subclavian artery in the posterior aspect, and it ascends upwards through the and parallel to the tracheoesophageal groove. So after the vagus nerve crosses the subclavian artery on right side, the right recurrent laryngeal nerve is given off, and it crosses the subclavian artery posteriorly and ascends. While on the left side, it is given off when this vagus nerve crosses the arch of aorta. This is arch of aorta, and it loops around arch of aorta and ascends. So arch of aorta and also ligamentum arteriosum. So on the right side at the level of subclavian artery and on the left side at the level of arch of aorta and loops around arch of aorta and ligamentum arteriosum and then ascends upwards. Okay. So which side is longer? Definitely it is on the left side. You can see that it goes down, loops around arch of aorta and then ascends. So this course of recurrent laryngeal nerve on left side is longer than that on the right side. So obviously the left recurrent laryngeal nerve is liable for injury during any surgeries on the cardiovascular areas, cardiovascular surgeries, and also during neck trauma and also during thyroid surgeries. It is more liable to injury than on the right recurrent laryngeal nerve because it has got a longer course. The chance of injury to left recurrent laryngeal nerve is more than that of the right recurrent laryngeal nerve. That you have to remember always. After looping around, the course in the neck is similar on both sides. So it ascends in the tracheoesophageal groove, trachea and esophagus. So it ascends in the tracheoesophageal groove or parallel to the tracheoesophageal groove, accompanied by inferior thyroid artery. Here there is superior thyroid artery, here comes inferior thyroid artery, and it enters the larynx at the level of cricothyroid articulation. This level only. But posteriorly at the level of cricothyroid articulation, it enters the larynx. So at that level, it can be anterior to inferior thyroid artery or posterior to the inferior thyroid artery, or it can go between the branches of inferior thyroid artery also. And inside the larynx, this recurrent laryngeal nerve has got an anterior branch and a posterior branch. Okay, so it gives off an anterior branch and a posterior branch, and this recurrent laryngeal nerve supplies all muscles of larynx except cricothyroid. Okay, and this posterior branches also supplies sensory fibers to the mucosa below the level of vocal cords, and this posterior branch of recurrent laryngeal nerve joins with the descending branch of internal laryngeal nerve, so that here it forms an anastomosis, that is Gallen's anastomosis. I'll write here. Okay, and this is important from anesthesia point of view. Gallen's anastomosis. Once you once you anesthetize this Gallen's anastomosis, the complete anesthesia of the larynx, both above and below the level of vocal cords, can be obtained. So that is the clinical importance of this Gallen's anastomosis. That is the descending branch of internal branch of external laryngeal nerve and posterior branch of recurrent laryngeal nerve inside the larynx. That is Gallen's anastomosis. Okay. So once again I will explain the path of recurrent laryngeal nerve. Both course after originating from vagus is different on left side and on right side. Left side, it is given off from vagus after the vagus crosses subclavian artery, and it loops or it goes up, ascends, crossing the posterior border of subclavian artery, and it ascends in the tracheoesophageal groove or parallel to the tracheoesophageal groove, and on left side it arches around arch of aorta and ligamentum arteriosum and then ascends. In the neck, the ascending pathway is same on both sides. It ascends parallel to the tracheoesophageal groove in company with the inferior thyroid artery and enters the larynx at the level of cricothyroid articulation. There it gives off an anterior branch and a posterior branch. This anterior branch is mainly motor and supplying all the muscles of larynx except cricothyroid, and the posterior branch is sensory, which anastomose with the internal branch of external laryngeal nerve, forming the Gallen's anastomosis. Pharynx and soft palate. So pharyngeal plexus, which gives sensory fibers to the pharynx and soft palate. Okay, so this is regarding the innervation of larynx, mainly by 10th nerve through external branch, external laryngeal nerve, recurrent laryngeal nerve and pharyngeal nerve, And also remember the Gallant's anastomosis, which is solely sensory and autonomic innervation to the larynx. Okay.